This afternoon, my lecture is going to focus on the ultrasound evaluation of cervical lymph nodes. And what I'd like to do along the way is to review the indications and ultrasound technique for evaluating these nodes, to emphasize certain anatomic landmarks for distribution of nodes, and really to focus on the criteria that we'll use for distinguishing normal from abnormal and discuss role and technique of ultrasound-guided FNA of these cervical lymph nodes. For the most part, the main evaluation of cervical lymphadenopathy relates to head and neck oncology. And I think it's fair to say that sonography has a relatively limited role in staging most head and neck cancers, and current state-of-the-art CT, MR, and PET are used primarily for many head and neck carcinomas, many of which are squamous cell carcinomas. The exception to this is in the patient with thyroid cancer, and here sonography is equal or superior to CT and MR in defining many of the characteristics of nodal disease. And of course, once an abnormal lymph node is found with CT or MR or PET, it's much easier, as we'll see, to be able to biopsy that lymph node with sonographic guidance. There has been some data to suggest that in comparing ultrasound with CT, that they're essentially of equal accuracy with papillary carcinoma, but ultrasound has the distinct advantage of low cost, lack of radiation, lack of contrast agents, and so it has become the technique of choice, particularly in the patient with papillary cancer in which we suspect there is involvement of cervical lymph nodes. It should also be pointed out that there's certain anatomic regions, such as the thoracic inlet, that are somewhat tricky to evaluate with CT, and this is a patient who had CT of head and neck read as a negative for lymphadenopathy. It's only in retrospect that we can see soft tissue fullness in the thoracic inlet. Now, the cervical lymphadenopathy is much easier to see with ultrasound, and of course, if we can identify things with sonography, we can then go on to biopsy. And this is an example of a recurrence of non-Hodgkin lymphoma that was much better detected with with ultrasound rather than CT. The point to be made is that there's certain anatomic areas, like the thoracic inlet, where ultrasound excels. Now, in terms of technique, we want to use the highest frequency transducer that will give us adequate penetration in the neck. And we say that for several reasons. Number one is to improve the spatial resolution, but number two is to improve the color Doppler sensitivity. And we'll be seeing that most clinically relevant lymphadenopathy is going to be along the jugular vein, what's called the lateral chain. And once we identify a potentially abnormal node with grayscale, we're going to go on to use color Doppler to further characterize that lymph node. So let's look at the key anatomic spaces in the neck that we're going to be looking at. And here you can see the submental and submandibular spaces. And then along the jugular chain, we have the upper, middle, and lower cervical chain, and then along the posterior triangle. Now, these spaces correlate to anatomic levels, and you'll hear head and neck surgeons refer to a level 2 lymph node. Well, that's right around the submandibular gland. In the mid portion of the neck, that's level 3, the lower portion 4, and posterior triangle 5, etc. And you'll also hear the term the central compartment, and these relate to nodes in the bed of the thyroid that are removed at the time of total thyroidectomy. So that's an important anatomic area as well, and we'll talk about recurrence in the central compartment for thyroid cancer. Now, in beginning our anatomic search for lymph nodes, we find it very easy to do a survey along the jugular vein to detect lymphadenopathy. And we can see here that levels 2, 3, and 4 really are the most prevalent sites that we want to investigate. There rarely are some metastases in the submental area, rarely in the posterior triangle, but levels 2, 3, and 4 really are the key anatomic areas. In terms of characterization of cervical lymph nodes, we want to look at 4 parameters: their size, their morphology, ectogenicity, and of course the color Doppler characteristics. Now, in terms of normal lymph nodes, again, it's important to recognize how the literature has designated by convention. The measurement of nodes is in the short axis. This is very critical because the long axis really is not a relevant measurement. In general, most normal neck nodes are elongated or oval, and they're not round. They tend to be hypoechoic, and they may or may not have an echogenic hilum, which may relate to fat in the central portion of the lymph node, or it may be related to acoustic reflectivity of the central lymphatics. Now, with color Doppler, normal neck nodes rarely have much color, but when they do, it always is in a pattern of central arborization, and that'll be very important as we distinguish abnormal neck nodes. Morphology and echogenicity always trump size in determining if the node is abnormal. It's a very important observation. Now, here are examples of classically normal neck nodes. This one has a clearly defined echogenic hilum. It's elongated. It has minimal flow coming in a central pattern. Again, I want to make the point that only the short axis of the node is a relevant measurement. And you do not want to be calling your clinician with this very elongated node and call this a 2.5 centimeter lymph node. It's really only a 4 millimeter node because the short axis is the only relevant measurement. And here are some other examples of normal elongated neck nodes. And by way of contrast, here's an abnormal rounded node that had metastatic thyroid cancer immediately adjacent to a normal elongated node. So morphology is often a key first finding for abnormal nodes. Now, is it the case that all elongated neck nodes are normal? No, because if we see abnormal echogenicity and abnormal color findings, that will trump the elongated morphology. And here's an example of papillary carcinoma involving the neck nodes, which has microcalcifications and cystic change. So we can see on the left, and then on the right in the color image, instead of a central pattern of arborization, now we have a peripheral flow pattern. So elongated lymph nodes may occasionally show other findings that clearly indicate involvement with disease. Here's another elongated lymph node where there are clearly evident microcalcifications. Now, microcalcifications are not, strictly speaking, specific for papillary cancer, although in the post-thyroidectomy patient, we rarely encounter anything else. But depending upon your patient population, cervical tuberculosis with granuloma formation may cause microcalcifications again, but that's a very rare phenomena indeed. Now, reactive lymph nodes tend to be slightly enlarged, but they're, for the most part, elongated, and they have slightly increased flow, but again, it has a normal central arborization pattern. The echogenicity is usually always normal, and these were lymph nodes that were biopsied and proven to be reactive lymph nodes in a patient who had pharyngitis. And again, see the elongated, slightly plump, if you will, morphology. Again, on color flow, there's a central pattern of arborization. And some reactive lymph nodes can be quite large, and we can be clearly confident that they're reactive, again, by the elongated configuration, the preservation of the echogenic fatty hilum, and the central flow. Abnormal neck nodes tend to be rounded, and they tend to have borders that are often irregular. That's not specific for tumors. Sometimes other infectious diseases, such as TB adenitis, may cause the borders to be irregular. Frequently, there's loss of the echogenic hilum, and often there are morphologic changes that we can see with grayscale that tell us that node is abnormal. We've seen some examples already with internal cystic change, calcification, or increased echogenicity. The color Doppler flow shows a wide spectrum of abnormalities, but basically it's some deviation from the pattern of normal central arborization. So let's look at some abnormal nodes and some examples of rounded morphology with lobulated irregular shapes. And here's an example of a patient with metastatic breast cancer. These are rounded nodes, and instead of having the central flow, peripheral flow. Here is a patient that has metastatic papillary cancer. Notice how irregularly marginated the node is with subtle but demonstrable cystic change within the node and markedly increased flow pattern, not that we would associate it with a normal flow pattern. These nodes, compared to the adjacent strap muscles, show increased echogenicity, and they have a rounded morphology. And these two are involved with papillary carcinoma. Here's another patient with rounded morphologic nodes, and this was supraclavicular lymphadenopathy related to lung cancer. Other rounded nodes we can see here with abnormal flow patterns and very rounded morphology related to lymphoma. And again, another case with rounded morphology, abnormal flow related to breast cancer. When we see marked nodularity or lobulation of the contour of the node, we have to consider that there's extracapsular invasion. And that's particularly common with a lymph node such as squamous cell carcinoma. Here's such an example. And we can see in the correlative MRI, the node is invading right into the muscle. The reason why that's important, as the surgeon goes to extract the node, forewarned that this is locally invasive, the head and neck surgeon will also take a surrounding cuff of muscle to get negative margins. So we can, when there's marked nodularity, often suggest that there is extracapsular invasion. Here's another example of abnormal morphology with irregular contours, and this too had extracapsular invasion. Notice the multiple areas of microcalcifications.